Hi, friends. This is Dr. Kamepalli. I'm an infectious disease, wound care, and obesity medicine board certified physician in LaGrange, Georgia, USA. And this is the talk that I'm giving for Indian Podiatry Association Andhra Telangana meeting uh, as a part of uh, educational event. And this is a long version of the presentation. And I'm going to talk on infection-focused wound evaluation, point-of-care diagnostic, and use of technology. And basically, my website is nobadbugs.com, and my Twitter handle is @woundphysician. And my hashtag that I use most of the time is removing barriers to healing. And my interests are nothing but working on telemedicine technology that helps improve infectious disease, wound care, and obesity-based solution. The objective of today's talk is to work on identifying the infection and clinical examination and biofilm-based identification and unique characteristics. And also the focus of the talk is going to be biofilm identification and point-of-care technology. But also I'm going to try to end up with and other options that are coming up in the wound care scenario using a platform-based solution also. So what are the major problems in wound care is nothing but issues with hypoxia, ischemia reperfusion, intrinsic host factors, and infection biofilm, which we're going to focus on. And we're not going to talk much about nutrition. Biofilm is a community of pathogens that are enveloped in a complex structure of entangled polymers strengthened with metallic bonds. Common wound healing problems are extracellular matrix dysregulation, increased bioburden, which is one of the problems with infection, and imbalance. There is biochemical imbalance, and also cellular senescence happens, and impaired angiogenesis as a problem that is significantly noted in wound healing, which is kind of contrasting when in a cancer situation, there could be excessive angiogenesis and growth of the cancer cell, whereas there is impaired angiogenesis. If you think about it, there is extremes of angiogenesis is seen, one with cancer and the other extreme with wound healing. So I somehow think that there is these both etiology of problems are on the ends of the spectrum of angiogenesis. Obviously, in wound care, there is wound hypoxia and there is malnutrition and pressure, which all of these we are not going to focus on. And today, we're going to talk about infection, which is one of the spectrum in the process of removing barriers to wound healing. So this was International Wound Infection Institute approach to signs and symptoms of infection, where there is contamination, where they contain microorganisms that will not multiply. And obviously, their presence is only transient. Colonization is successfully low-grade growth of bacteria, but no damage. Whereas local infection, there is hypergranulation, that is friable tissue, and also there is wound breakdown, and there is delayed wound healing. And over sites of local infection, including erythema and local warmth, delayed wound healing, and also increased odor. And spreading infection could be local induration, lymphangitis, and inflammation, and also lymph node changes that are starting to become septic when systemic infection happens and organ failure damage happens. You can diagnose these with the deep tissue biopsies, needle aspiration, swab cultures, and PCR technology is being employed now. So what happens with the infection is there is host resilience, the problems, and also there is local wound environment that changes, and also host factors and microbial burden. There could be cross-contamination, there could be polymicrobial infection, but also everything depends upon the microorganism virulence factors, and also wound environment that is present with exposed hardware. There could be necrotic tissue, there could be excessive exudate present, but also host factors with patient having obesity and problems with nutrition, diabetes, and immunosuppression could be contributing. In an acute wound, there is microbial colonization, wherein there is a virulent bacteria present, and also there's chronic classic host inflammatory response, wherein there could be neutrophil oxidative changes and also neutrophilic extracellular traps, netosis, that is nets where there is increased nets present, and then we can use systemic antibiotics. But when it comes to the chronic wounds, though, there could be problem with recalcitrant wound, wherein then we have to then go ahead and work on debridement and also wound hygiene techniques. And we need to understand that there is difference between acute wounds and chronic wounds, with the clinical manifestations could be different with both of the wounds. Whereas in chronic wounds, there could be increased exudate, there could be friability of the tissue, and there could be significant hypergranulation changes. And also there could be inflammatory response that is more low grade with interleukins and tumor necrosis factors. And also there could be excessive accumulation of nets. There could be something called as persistent netosis. And there could be release of more neutrophils and slow-grade inflammation present. And Infectious Disease Society of America come up with evaluation management for diabetes, wherein they come up with options for stepwise approach, including using surgical debridement, addressing the concept of peripheral vascular disease, optimal blood glucose control, and making sure that there is significant offloading technique, and also glycemic control with significant improvement in metabolic fitness that is needed, and also other key comorbidities that need to be addressed, including transportation barriers, housing, and also language and difficulties with access to healthcare. These have to be brought into this concept of comprehensive diabetic foot infection approach. So we have to understand the concept of wound, ischemia, and infection, Wi-Fi classification. Also, we have to understand that in diabetic foot wounds, there is a tissue loss, and this tissue loss could happen in patients with diabetes because of sensory loss, where it leads to mechanical problems and leads to autonomic and vascular problems that leads to local hemorrhage and inflammation. And obviously, if you think about this in the cardiac coronary disease, when also there is atherosclerosis happening, at one point there is intra atherosclerosis hemorrhage. And if you see, this is something similar, where there is more callus forms and intracallus hemorrhage forms. And obviously then that leads to wounding that happens. Now, we need to check on different approaches, including trying to understand what is the level of the wound, whether it is shallow, whether it is deep or extensive, and also come up with this ischemia ABI done, with also transcutaneous oxygen testing being done with the TCOMs, but also now there is a near-field infrared testing that is being used in a non-invasive quick methodologies. And also to come up with what is the level of infection, with erythema being 0.5 to 2, when level 2, when it is more than 2, and level 3, when it is there is significant infection with systemic inflammation and elevated white count changes. Now, the approach would be trying to understand that if the patient is there, then we have to, if there is a level of what is the level of infection or ischemia, and basically trying to grade it. And when there is a plantar wound, whether we should follow up with surgical offloading, or whether we have to then go ahead and find out if there is bone infection and osteomyelitis, then we have to do debridement, and obviously control different aspects, including vascular status and options for that. And testing the patient's lab parametrics are also important, with C-reactive protein, procalcitonin, also perspirin, and then now DNA technology with microbial DNA can be used. Also, newer approaches are trying to detect bacterial proteases. Now, proteases, which are matrix metalloproteases that are being detected, also are secreted by the bacteria and also the host MMPs. So these need to be detected, and there are new technologies for protease detection that are being upcoming. Now, we have to understand the sequence of healing. We all know about hemostasis, which happens, then inflammation, repair, and remodeling happens. These are the 4 phases of healing. But when the wound is non-healing, it is getting stuck in a chronic inflammatory phase, wherein in this chronic inflammatory phase, there is prolonged elevated inflammatory cells with the neutrophils that is present, and increased macrophages. And these macrophages could be M1 kind. And there is inflammatory cells or MASH cells that increase the matrix metalloproteinases. And also, when there is a balance between MMPs and tissue inhibitors of MMPs, and there is a increased reactive oxygen species, that's when the wound becomes prolongedly inflamed. And essentially, the growth factors are reduced and the wound becomes chronic. Now, what is the common factor mostly happens with these chronic wounds? Either it could be arterial, venous, traumatic pressure, or any other etiology. It is that the wound gets stuck in the normal wound healing consequence. The wound does not progress, and there is significant stalling that happens. And this happens because of persistence of wound that is biofilm that is present, mostly noted in even 60% of biopsies in chronic wounds, and 60 to 80%, and even in acute wounds too. What is biofilm? It's a surface-associated microbial community that is composed of various phenotypes and commonly various genotypes that encase themselves in the 3-dimensional matrix of extracellular polymeric substances, that is polysaccharides and nucleic acid proteins, that demonstrate significant resistance. This was detected as a theory in 1978 with essentially slow detection noted in multiple aspects of our daily living, including cooling towers, oil refineries, ship hulls, drinking water, healthcare industry. It is noted mostly in the dental industry. And obviously, new advances with medical implants are also showing this problem. What is the problem with this biofilm? Is there is biofilm bacteria secrete communication signals. These are called homoserine lactones. These homoserine lactones continue to accumulate, and the bacteria have a signaling communication between themselves. It could be MRSA, it could be Pseudomonas. They keep talking to each other, and basically, after a certain time, when there's adequate amount of homoserine lactin accumulation, there is something called as quorum. That is, when a meeting starts, a quorum is formed. Similarly, when an adequate amount of bacteria that happen to accumulate, then quorum is happening. And obviously, this happens, this happens as the surface attach happens and biofilm bacteria mature. And when there is maturing, there is quorum sensing happening. Now, we are using different conventional technology like DNA screening or electron microscopy or confocal laser microscopy and RNA-based technology. There are other novel improved methods, including detecting the pH of the wound bed, and also temperature sensor and biomarkers are being used to detect the bacteria, and advanced technologies that we're going to detect, we're going to discuss here. As we discussed earlier, biofilms are identified in 80% of the bacteria in chronic wound, but only 6% in acute wounds. Now, the problem with biofilm is that the bacteria are easily can be killed by antibiotics. But what happens is when there is fluorescent bacteria, then that are metabolic active, they are killed. But when they have a biofilm matrix surrounding it, antibiotics will not actively kill the bacteria. That is a problem that we have to address. And tools for detection have to be significantly deployed. Um, we have to understand that there could be wound failing by itself is an indication that there is biofilm on the wound bed, and formation of necrotic tissue that is easily friable is one thing that has to be looked into, and also failure of antibiotic therapy, and also wound having the slime on the wound bed, wherein you see like a slime on the base of the fish tank or an aquarium. You clean that fish tank, but the question is, we have to understand that it is a similar biofilm that's building on the wound bed, and also wounds don't heal right, and they continue to break open. So we are using different technologies, including RNA, DNA-based analysis, genome analysis, and biofilm imaging technologies are being used, and confocal laser microscopy to visualize bacterial biofilm in real time, and also detecting technologies including wound blotting, where they're attaching nitrocellulose membrane for 10 seconds, and you're able to detect and say, okay, there is biofilm there. So we have to understand that the biofilm by itself has exopolymeric material, and this dense matrix impairs diffusion of antibiotics, and basically we are not able to kill the bacteria. These persistent bacteria end up that are persisting in the wound bed on the deeper side, and antibiotic can only kill active bacteria. And oxygen is depleted in the center of the wound bed and promoting the anaerobic growth of bacteria. So basically, there is synergy between different kind of bacteria talking to each other, and these bacteria need to be deployed by local care, including use of hypochlorous acid. So we need to apply different biofilm-based techniques for wound care. These include short debridement, using fast-acting antimicrobial dressing, and also using identifying techniques to detect the different bacteria using DNA bacterial identification technique, or also use different step-down approaches to rapidly decrease the biofilm, which we're going to talk about. So one of the best approaches is vigorous cleaning and repeat debridement, and using aseptic techniques, and frequent reassessment has to be done. When the wound is not healing or persistent necrosis is there, we have to continue to work on effective topical antimicrobial therapy, and institute adequate wound care techniques, and continue with standardized wound care and continually assess. So the biofilm strategies include inhibition of the biofilm by altering the physical properties of biomaterial, and also we have to figure out how we can use anti-quorum sensing peptides that are available, and also there is new techniques of using nanoparticles on the wound bed, and quaternary ammonium compounds that are available can be used to clean the wound bed, and cell lysis and disruption, antimicrobial lipids and bacteriophages are being used outside US, and newer broad spectrum antibiotic therapy can be instituted diligently, making sure that appropriate infection control techniques are employed. Now, coming to the point of care techniques, wound tracking is something that is very important. So taking a picture at one time in a single episode really doesn't help, whereas sequential pictures wherein the trend of wound healing that has to be evaluated and tracked. So basically tracking is needed, and sequence out of people try to do this out of memory or single episodes of care, but unless we track it, we cannot trend it, and we cannot institute appropriate changes. Now, the technologies that are being used include fluorescent imaging technologies, but also the different ways in which bacteria produce different porphyrin-based expressions, wherein bacteria can be easily detected with staph, and Streptococcus pyogenes and Pseudomonas can be detected because they produce porphyrins, whereas other bacteria, Staph epi, Enterococcus, and Propionibacterium and Corynebacterium don't produce this porphyrin. And also, the newer technologies wherein fluorescence-based imaging are being used, wherein a certain light is projected into the wound bed, and we are able to detect what kind of bacteria are present in the wound bed. Like if there is porphyrin-produced bacteria, it could be, like we talked earlier, it could be staph, and also it could be Streptococcus. But if there is exclusively Pseudomonas, the color that produces out of it is cyan color, and also it could be white, but tendon could be white too. So this is where this technology by Moleculite is coming, wherein fluorescent emission with violet light is projected into the wound bed, and the different bacteria elicit different refractory changes, and basically optical filters are used, and once the optical filters are used, we are able to detect different kinds of bacteria. This is essentially used significantly for using bacterial identification, and also to see if there is any spots that need more attention in the ulcer bed. Now, one of the other approaches for decubitus ulcer detection is hyperspectral imaging, where the temperature of different areas are evaluated at admission, wherein you're able to assess the hyperspectral imaging, wherein the oxygen diffusion is detected, and depending upon the follow-up pictures, and to say that if the patient has acquired the infection at the admission or post-admission, we can then down the road associate whether this is a decubitus ulcer because of presence of these heat changes that were present at admission. Also, depending upon the oxygenation of that area, we can detect it if we document it earlier at admission. So the other better technology is near infrared spectroscopy in basically 700 to 1100 near infrared spectroscopic light is used, wherein the point of care can be used as a point of care diagnosis, wherein oxygen is diffusing, and this is a non-contact way in which we can capture oxyhemoglobin versus deoxyhemoglobin, and also make a decision regarding whether the therapy that is being instituted with if this could be a hyperbaric therapy or continual diffusion of oxygen. We can see if this therapy could be validating the changes that are happening. And obviously, this technology appears to be promising for the future. So the one thing that is very neglected is pH and temperature in the wound bed. So when the wound is acutely injured, there is a pH spike that happens. But also, as the chronicity of wound happens, the pH increases. And unless the pH of the wound is starting to slowly go down, the wound will not be healing. Also, obviously, we need to know that when the wound is not infected, also the temperature of the wound bed is also going up. So pH detection techniques, and obviously understanding that, and employing different pH-based sensors, wherein pH is nothing but potential of hydrogen. And basically, there are different indium tin oxide electrodes that sometimes can be detected that could be used on the ulcer bed. And obviously, this is something that is very much going to change how we use data to improve the outcomes, and by quickly tracking and appropriately instilling different interventions into this wound healing process. So the the bottom line is we have to understand that the pH is very important, and alkaline pH will not help us heal. And basically, wound alkalinity, this was a study that was done where they found that wound alkalinity at the second visit would predict a non-healing wound. So we have to understand that as the normal skin is pH is having pH around 5, and chronic wound with infected wound have increased pH. And when the pH value is a dynamic factor, and we have to make sure that we track it too. And there was one study that I came across which tracked a continuous wound monitoring using wearable technology, finding uric acid in the wound healing, wherein they found that the alkalinity increases inflammation, and basically they found that progressively as the pH continues to drop in the wound, there is more changes wherein the uric acid also changes, and they found that the pH and the uric acid levels are very much valuable in determining where the pH is going and how the wound is improving. So that was a significant thing that I noticed. But also, the one other factor is lactate in wound healing. This is where I say the cancer and wound care are the extremes of the same spectrum of healing. Whereas in a cancer, if you see the wound, the cancer cell by itself does not have excess lactate, but the cancer surrounding the tissue has high lactate, wherein there is anaerobic environment, and there is something called as cancer cells using Warburg effect, using glucose, producing excess lactate. So, but in the problem with wound care is there is less lactate in the wound bed. Now there are different tools and techniques and different dressings that are coming out that produces local anaerobic effect, wherein that stimulates the in a normoxic condition outside, the wound bed itself is going to be converted into local hypoxia, which stimulates HIF1 alpha factor that tricks the cells to think that there is hypoxia, increasing vascular endothelial growth factor expression. And that modulates the inflammatory environment and MMP expression, and enhances cellular growth. And obviously, basically, the pH is changing, and this effectively helps changing the signaling pathways, wherein cellular metabolic pathways involving lactate production help the bacteria, wherein when the cells become when the cells die, also the macrophages that are converted into from M1 into M2 macrophages, and this signaling pathway with this process of efferocytosis induced lactate enables pro-resolving macrophages and converting M1 macrophages into M2 macrophages. That is very effective also in healing. So another aspect of local interventions that is thermal imaging that is being done now with cytokines that are present at the pressure ulcers, wherein two nurses can go in and capture the visual infrared images in the sacrum and coccyx and heel areas, wherein if the same anatomical location, if future ulcers happen, we have a documentation showing that this pressure ulcer is pressure changes were present at the time of admission. So this is one technique that healthcare institutions might want to start inputting to document, so that this is one of the things as a proof to show that in a multiply challenged patient, it is more than nursing, which does not absolve the nursing staff from appropriate turning and appropriate active local wound care, whereas moisture, pH, and temperature do play a significant part along with multifactorial issues that have to be addressed with monitoring, tracking, and involving different tools, techniques, and processes. Also, we are, like I was talking about, bacterial proteases are important virulence factors that are produced. Gram negatives and gram positives produce different bacterial proteases, but also human body produces different bacterial proteases that can be easily tested by the swab technique, wherein the anti-protease dressings can be used appropriately as soon as increased protease activity is detected. Also, at the point of care, simple techniques wherein new vascular evaluations could be instilled, and also microvascular and macrovascular diseases are detected, including autonomic testing and also vasometer testing can be used to detect the significant peripheral vascular intervention, peripheral vascular disease that contribute to the point of care evaluations. So we have to understand that debridement, accident management, infection control, pressure, nutrition, and offloading are important. Also, we understand the concept of nurse and stories, that is ingrained discussion in basics of wound care, but also understand that there is a significant need to understand colonization, contamination, and spreading infection, and also stepwise approach to biofilm-based wound care with active wound care as a approach to wound healing rather than passive approach for appropriate patients at the appropriate time at the appropriate location, and then try to de-escalate and continually evaluate and do appropriate healing standard care using advanced dressings, growth factors, negative wound therapy, and advanced stem cell or placental-based products that can be used to hasten the healing. And obviously, different technologies that are being used, including early antibiotics, chemical debridement, mechanical debridement, and using ultrasonic debridement, wherein you can produce micro bubbles on the ulcer bed, and also ultrasound targeted micro bubbles with vancomycin are being used at different areas. And obviously, nanoparticles are being used, also use metals that can be used, including silver nanoparticles and zinc nanoparticles, and gold nanoparticles are also being used along with mechanically debriding the ulcer bed. So you have to understand that ultrasound therapy is a significant newer intervention that is being used at the bedside, at the point of care, wherein intensive waves of ultrasound that are being used with basic treatment ward where the ultrasound is applied, also applied the acoustic current towards the wound bed in a bubble cavitation production, wherein the ultrasound therapy can rupture and fragment the bacteria. This technology is simple to do at the bedside, and it can be used for multiple different ulcers. And obviously, different tools, techniques, and processes have to be installed, but in overall care of the patient. But we have to understand that the major factor in wound healing is not just bacteria, not just biofilm, not just perfusion, and also pressure, our wound mechanics, but also we have to understand that there is multiple other comorbidities, including nutrition, metabolic fitness, access to care, and also the genetic makeup of the patient, and also genomic profile of the wound bed. And we have to understand that the ulcerated wound is compromised, and the host then is compromised. The real care should be a whole person care, not the hole in the person care. While we should understand that point of care solution help, but we need a platform-based approach to healing, integrating people, process, and technology through a medical professional-driven patient empowering solution. Now, the reason to do this is to understand that we have to be able to predictively analyze what's going on and prevent the further worsening. and we have to use data. We have to then come up with the right kind of data in the hand of the patient and the professional, recruit the right kind of team, and also create a culture of change wherein we have to go ahead and instill the positive changes in healing. And also, we have to implement these approaches of patient safety and prevention, and also identify well-defined use cases for different approaches in healing, as one size does not fit all. And there are different barriers to caring for each patient and each wound. And we have to understand that there is big data, there is different targeted use cases, and also we have to understand that we have to use integrating analytics into each patient-centered workflow. And also we have to drive different technologies and drive adoption. And to do that, we have to use a platform-based approach. And we have to use electronic health records all in one place, empower the doctor, the patient, and also help the patient with remote patient monitoring, chronic wound healing, like temperature tracking of the wound at home, and also improve the metabolic parameters of the patient. And wound care by itself is not a hole in the patient, but we have to address the whole patient, what is going on. Say, for example, stress can cause cortisol increase. That can cause pain in the wound bed. Stress by itself can, in a happy day, the patient does not feel pain in the wound. That is cortisol in action. We have to understand that this whole process is a symphony. There is a rhythm to nature. There are rivers. You can see the rivers, you can see the blood vessels, you can see the trees, and also different music notes. Everything has a rhythm. We humans have to recognize it. And we are missing that in healthcare. And we need to start thinking about how we can include a whole person approach in care delivery. Thank you very much for giving me this opportunity to discuss this. And we'll have the resources in the end of the slideshow. Thank you very much and take care.